Welcome, everyone. My name is Amy Henriksen. I'm a medical affairs manager with Nestle Health Science. I am thrilled to introduce today's speaker and assist with the webinar entitled Pediatric Feeding Disorder, a Practical Approach. I am very pleased to present today's speaker, Dr. Jaime Phelan. Dr. Phelan is a clinical professor of pediatrics at the Uniformed Services University and adjunct professor of pediatrics at UT Health San Antonio. He's also the medical director for Feeding Matters, Inc. Dr. Phelan earned his medical degree from the Uniformed Services University of the Health Sciences F. Edward Hebert School of Medicine in Bethesda, Maryland. He completed a pediatrics residency from Keesler Medical Center at Keesler Air Force Base in Biloxi, Mississippi. He subsequently completed a developmental behavioral pediatrics fellowship at the Children's Hospital JFK Partners in Denver, Colorado in 2005. He was chief military consultant to the Air Force Surgeon General for developmental pediatrics. In December 2016, he retired from the U.S. Air Force after 28 years of service. Dr. Phelan is American Board of Medical Specialties certified in general pediatrics with subspecialty certification in developmental behavioral pediatrics. He's a member of the American Academy of Pediatrics and has presented nationally and published in his field. Currently, he works for University Health System in San Antonio, where he continues with teaching pediatric residents and seeing patients full-time. And now I'm very pleased to hand the program over to Dr. Phelan.
Thank you for the introduction. This is Jaime Phelan, and I'll be walking you through the world of pediatric feeding disorder. And the reason that we're talking about this is that I think that it's a widely under-recognized and misunderstood condition, and I'm hoping that by taking you through this, you'll have a better understanding of exactly what it is. So the objectives for you as listeners and learners is to be able to describe a normal feeding pattern in children. We can't really talk about pathology until we talk about normal. Be able to identify common feeding problems in pediatrics, in other words, normal variations. Explain strategies on how to avoid or at least prevent feeding problems. Recognize the difference between feeding problems and pediatric feeding disorder. And then finally, how to manage PFD. So until January of 2019, there was really not a universally accepted definition of pediatric feeding disorder. Previous paradigms came at this from the point of view of a single discipline, for example, speech-language pathology, child psychology, psychiatry, gastroenterology, or developmental pediatrics. And each organization had its own approach to it, but there was not a single unifying approach. So in January 2009, we published a consensus article titled Pediatric Feeding Disorder, and our goal was to use the World Health Organization framework to identify it. And we look at 4 domains, which I'll cover later: medical, nutritional, feeding skill, and psychosocial. And what we were hoping to accomplish with this was to come up with a common, precise terminology necessary to advance the science of feeding disorder and hopefully help with treatment, recognition, research, and treatment. So 15 of us worked on this starting in March of 2015. It took almost 4 years to get it published. There were 7 disciplines. And as you can imagine, with different disciplines, we had to compromise quite a bit. But it helped us each grow as individuals. There's not one person, not one specialty on this list that's more important than the other. So we all worked together, everyone pitched in, and we did a comprehensive review of the medical literature. This is the title of the article. It was published in 2019, earlier this year, in the Journal of Gastroenterology and Nutrition. So let's start off by talking about normal feeding, because like I said, we can't really talk about pathology until you know about normal. So normal feeding involves coordination of multiple body systems. And if you think about an infant going from birth until they're maybe toddler, 3 years of age, there is a huge progression of food selectivity with oral motor skills advancing, the types of foods that they accept, and its impact on growth. So one thing that a lot of parents do not recognize is that children, neurotypical children, can vary their oral intake up to 30% daily with no impact on their growth. So putting it in parent terms, your kid can basically skip one meal per day and still be healthy. And a lot of parents are under the impression that, you know, the way we were raised, or at least I was raised, was you must finish everything on your plate, and if you don't eat, you're going to sit there till you're done. And that's actually a very unhealthy approach. And so by knowing this, you can actually relieve parents of that guilt or that misinformation. Now, if you think about feeding and thinking back to celebrations like Thanksgiving and family gatherings, feeding plays a central role in the relationship between the child and the caregiver. It does not occur in a vacuum. So what's normal as far as feeding problems? So food selectivity, AKA picky eater, or as they say in England, a fussy eater. I like to call them a big pain in the you-know-what. So these are kids that one day they like one thing and the next day they hate it, and they go back and forth. I don't like that. But it doesn't really affect them. These are just kids that they're kind of using their mouths as a control mechanism. It's usually not a problem. Also very common is reduced appetite for or reduced interest in certain foods. And then an article that was published back in 1966 looked at children from birth to 18 years of age, and the average time to complete a feeding, whether it's breast, bottle, or table foods, is about 30 minutes. So anything over 30 minutes is considered too long. So that's a helpful number to remember. And most kids will be able to finish a meal in about 10 to 15 minutes. It's also normal for kids to pocket food in their cheeks once in a while, as long as they can swallow the bolus. So some of these kids look like little hamsters, but they're no worse off. So when we look at children across the board, neurotypical children, anywhere from 25 to 50% of them can have feeding problems that I've just discussed. And about 3/4 of those kids that have developmental disabilities, for example, autism spectrum disorder, global developmental delay, intellectual disability, 80% of those kids can have feeding problems. So this is not something that you don't see. This is something you should be seeing in your clinic on a daily basis. So again, that was normal. Those are common feeding problems, but there's no impact on the child. So now we're going to talk about pediatric feeding disorder, or PFD. So as I said, it previously lacked a universally accepted definition, but we're going to go through hopefully what we consider a better one. So this is from the point of view of speech language pathologists. Their organizing body is ASHA, and their focus is solely on oral motor skills, pediatric dysphagia or oropharyngeal dysphagia, impaired pharyngeal, oral, or esophageal phases of swallowing. That's the basic premise there. So these are kids that have difficulty chewing and swallowing, so they might present with gagging, choking, or coughing, but this neglects other problems with feeding. World Health Organization, ICD-10, published in 2016. So they look a little bit broader, but they look specifically at infancy and early childhood, and they're kind of taking a behavioral approach. They're talking about food refusal, extreme fattiness, again, these are British terms, and the absence of organic disease. So this goes back to the very outdated organic versus non-organic kind of dichotomy that we've abandoned more than 20 years ago, and it's going back to that. So this is taking a behavioral approach, and again, it's not that helpful. In May 2013, the American Psychological Association published the 5th edition of the DSM, which is our diagnostic Bible for neurobehavioral disorders. And they came up with a new diagnosis called avoidant restrictive food intake disorder, or ARFID. Sounds like BARFID. It's not very helpful. It does have a little bit broader approach than the previous two, but again, there's something missing. So again, the focus is on, they have food available. This is not part of their culture, and the child has to be developmentally normal. So automatically, we're excluding any child who has a developmental disability. So if the child has autism spectrum disorder, they cannot have this diagnosis. If they have Down syndrome, they cannot have this diagnosis. They made it clear that they do not want this being confused with an eating, E-A-T-I-N-G, eating disorder, such as anorexia nervosa or bulimia nervosa, and it cannot be attributed to a medical condition. So again, if the child has oropharyngeal dysphagia, If they have another mental disorder, they cannot have this diagnosis. And if they do have any diagnosis, this has to exceed what you would associate with that condition. So it's very restrictive. They do recognize the importance of sensory aspects of food. So some children are exquisitely sensitive to the look, the smell, the taste, the color, the temperature of food. You may have seen this in your practice where children will prefer a chicken nugget from one place only, or the food has to all look uniform. It can't look like it's burned or charred or broken. So this presents with feeding refusal. They do recognize that some of these children will have autism spectrum disorder because ASD, one of the criteria in there is the sensory sensitivity. It's also important to recognize that some of these children have developed a conditioned negative response. So for example, if they underwent a procedure or if they've had frequent choking or vomiting, they may learn to avoid certain foods that they perceive caused those symptoms. So associated features that support the diagnosis is lack of interest in food, young infants that are too sleepy, distressed, or agitated to feed. In my practice, I've actually had two what I would call, quote, night feeders or sleep feeders, unquote. These are infants who were unfortunately traumatized by aggressive bottle feeding, and they refused to take feedings by bottle, by mouth. And they learned that once they fell asleep, they could feed. And I did not believe that until I actually saw it. So there are some cases like that. These kids often have difficulty engaging with primary caregivers. And with the two that I saw, as soon as the parents handed the child off or the infant off to nursing staff, the child would feed fine. And you put it back in the parents' arms and they would again stop feeding. And then in children, adolescents, they can have generalized emotional difficulties. So they're alluding to things like major depressive disorder, anxiety disorder. So what are the problems with ARFID? Well, like I kind of said, it excludes children whose primary challenge is a skill deficit. In other words, oral motor delay, oropharyngeal dysphagia. The other problem is that the feeding disturbance must exceed that associated with the comorbidity. There is no limitations regarding age of onset. And in a study done at an eating disorder clinic, despite ARFID excluding eating disorder, 29% of those teenagers still met criteria. There was significant overlap. So it lacks specificity. So our definition proposed for PFD is impaired oral intake that is not age appropriate and is associated with medical, nutritional, feeding skill, and or psychosocial dysfunction. So the key words there are impaired, age appropriate, and dysfunction. So for example, ADHD, the last word is disorder. Autism spectrum disorder, the last word is disorder. Those children experience dysfunction. The same thing here. Pediatric feeding disorder, by definition, we have some kind of a dysfunction. So we're not talking about picky eaters. So PFD results in disability as defined by the WHO. And we talk about impairment, activity limitation, and participation restrictions. So examples would be a child who has severe maladaptive behaviors, tantrums, and no longer gets invited to birthday parties because they can't stand the texture of the frosting on the ice cream, or I'm sorry, on the cake, something like that. Or a child whose parents avoid going out to restaurants because the child will not tolerate the foods that are offered there. That would be an extreme example. So our proposed diagnostic criteria is a disturbance in oral intake of nutrients that is inappropriate for age, lasting at least 2 weeks. The reason we emphasize 2 weeks is because we want to make sure that this is not a fad or a trend, or it's not just something that is going to kind of go away, like I said, picky eating, that child changes his or her mind every other day. There has to be one of the following areas affected. So the first two are medical and nutritional. So medical could be some kind of cardiorespiratory compromise. So these are kids maybe are desatting, or maybe they're having recurrent aspiration pneumonitis, things like that. For nutritional dysfunction, it could be malnutrition, weight faltering, also known as failure to thrive, or specific nutrient deficiency. I actually just saw a child this morning whose primary care provider was very concerned. He has 5 to 10 foods in his repertoire. He's 3 years old. No dedicated sources of protein other than yogurt. PCP was smart enough to do some baseline labs and identify that this child was deficient in both calcium and iron, so this kid has anemia. So that would be one criteria. And then reliance on enteral feeds. So any child who has a gastrostomy tube or oral supplement, so toddler formulas, that would meet criteria. The next two areas that could be affected is feeding skill dysfunction. So this is a child who needs texture modification. So in other words, a 3-year-old who is eating pureed baby foods, or a 12-year-old, which I've seen in my clinic, that is living on jarred baby foods. That's an extreme example, but I've seen these things. Modified feeding position or equipment. So kids that have to have some kind of a special spoon or a feeding chair, or modified feeding strategies where parents, caregivers, therapists are going above and beyond to get the child to eat well. As far as psychosocial dysfunction, what we're looking for there is some kind of avoidance. This could be a kid that simply turns his head away when they're offered a non-preferred food, or the more active child who actually is throwing the food across the table, across the floor, having tantrums, screaming, crying when a non-preferred food is presented in front of them. The second one I see quite often, inappropriate caregiver management. Parents will try anything they can to get kids to eat better, and oftentimes their guilt takes them down the wrong path. So I've had multiple parents force feed their children, punish their children, spank their child because of their dietary repertoire, when in fact this is not behavioral. There might be something else going on. Disruptive social functioning could be some kind of impact on where they go to travel or who they visit, and then impact on the child-caregiver relationship. So this is similar to the ARFID from the DSM-5, and basically we want to make sure that this is not due to a cognitive process consistent with an eating disorder. So again, we strongly agree with that recommendation from DSM. We also want to make sure that it's not due to lack of food, because a lot of children that live in poverty have limited opportunity to eat certain foods. You may have heard of the word a food desert, where children live in the inner city that don't have access to fresh fruits and vegetables. That would not meet criteria. Or a child whose eating pattern is congruent with cultural norms, where everybody in the family is eating the same food. So this just basically shows the 4 areas that interact back and forth that can lead to PFD. And none of these is more important than the other. Most kids will have a little bit of each. So we're going to go into a little bit more depth about medical factors. So things that put children at risk for PFD include prematurity. This seems inherent, but maybe not. These, if you think about it, an infant born before 34 weeks of age is not fully capable of oral feeding, and oftentimes needs some kind of a gavage feed. Cardiopulmonary disease, a child that has severe congenital heart disease can have difficulty feeding just because of the extra work involved. Genetic or chromosomal anomalies like Down syndrome, craniofacial anomalies because of the structure involved. This would include things like cleft lip, cleft palate, Pierre-Robin sequence, neurodevelopmental disorders, and gastrointestinal disorders. So touching briefly on neurodevelopmental disorders themselves, one of the more common ones is autism spectrum disorder. As I said earlier, DSM-5 recognizes the importance of sensory sensitivity, and a lot of these children are oversensitive to the sensory aspect of food. Children have either global developmental delay or intellectual disability, can often have problems with feeding, and from a motor aspect, children who have cerebral palsy or similar conditions. Gastrointestinal disorders would include things like gastroesophageal reflux disease, not just GER, but GERD, where these children are actually refluxing, and the refluxate is causing the child discomfort. Chronic constipation. I see this all too often, where we're focusing on the in, but we're not talking about the out. And I make it very clear to parents that the feeding tube is just that, and if the bottom of the tube is full of stool, there's not going to be any room at the top for food. So this gets missed very often. Parents think their child's having normal stools when in fact they're severely constipated. The child could also present with what the parents, or in some cases the PCP, considers diarrhea, when in fact it's overflow incontinence, where you have a huge obstructed bowel with liquid stool leaking around it, and it gets treated incorrectly. And then a relatively newer diagnosis in the last 10 years or so is eosinophilic esophagitis, where children have an allergy-like presentation affecting the lining of the esophagus triggered by certain foods. It does not respond to typical medications for GERD, and they can avoid a lot of different foods. So this is something to consider in a child who appears to have GERD, but is not responding to a reasonable trial of PPIs. That's a kid you would want to send to gastroenterology. Nutritional factors. So restricted quality, quantity, or variety of foods. So I have some children who are eating quite a lot of food and they're actually obese, but their quality of the food is terrible, or they're not eating enough of a variety, or inadequate energy intake. Children who are not getting enough calories and their body mass index is falling off the chart, or children who omit entire food groups, or they eat too much of a certain food. So this would be a child like the one I told you about that I saw this morning, who has truly no dedicated source of protein other than yogurt, and those kids are at risk for micronutrient deficiency. This is often overlooked. So infants who are born SGA or small for gestational age, depending on which definition you use, birth weight less than 3rd or 10th percentile, but basically these are children who are born smaller than expected for their gestational age. So it could be a fetal issue, something to do with the environment leading to growth restriction, or it could be more constitutional, that the child just comes from small stock. Parents are short, or they're very small people weight-wise. Importantly, up to 50% of infants that are born SGA will not catch up by age 2 years. So that's quite a big chunk of these kids. So we need to keep an eye out for them. They are at greater risk for having long-term growth problems. Weight faltering, also known as failure to thrive or poor weight gain. This is often over and misdiagnosed. So I want to really focus on this. The most accurate definition is a sustained decrease in growth velocity, looking at weight to length ratio under the age of 2, or body mass index after the age of 2, under the 5th percentile. So you notice I don't say anything here about weight, because weight's not a useful measure. So looking at the growth chart, here this child has average height, 50th percentile-ish, but when we look at his weight, it's always well below that middle line. So this child would have failure to thrive because the weight is much lower than the height. You don't even have to look at the weight for length ratio. You can tell by eyeballing that the kid is going to have weight faltering. So causes, not enough going in, too much going out, too much being used, or poor absorption. And you want to make sure that you plot these children on the appropriate growth charts. So weight faltering can lead to malnutrition, and if it's severe, it can affect linear growth, and in rare circumstances, actually head circumference. So the body spares the brain, but there are rare cases where weight drops, length drops, and then the head circumference drops. And it's not that they actually decline, it's the rate of growth declines. So now we're going to talk about feeding skill factors. So this is anything to do with the mouth or the hands. So an illness, an injury, or developmental delay, impaired oropharyngeal or sensory motor function, or an altered oral experience. Any of these can cause a feeding skill problem. So oral motor delay. These are children who have oral motor hypotonia. How do you recognize that? This is a child who has an open mouth after the age of 12, drools after the age of 12 months. They have difficulty lateralizing their tongue. They're not moving that bolus back and forth. Or when they eat, they're quote unquote messy eaters. They're spilling food or liquid from the mouth when they eat. Or in very small infants, that sucks full of breathe pattern that is normal isn't there. So they're having difficulty having that all coordinated. So oftentimes we'll start gasping or choking or coughing. And in severe cases, that can lead to aspiration. So the ugly cousin to oral motor delay is oropharyngeal dysphagia. So this is oral motor delay with complications, basically. So it's pathological difficulty swallowing is the most concise definition. And it's usually due to an underlying neurological or structural abnormality. So again, these are the kids that go beyond just the gagging, but they're actually having some other issue consistently during feeding. So vomiting, apnea, cyanosis, and then complications include aspiration or pneumonitis. This is a red flag. The last category, and certainly not the least, is psychosocial factors. So developmental delay and the presence of unrealistic caregiver expectations. So let's think of maybe a 5-year-old female who has intellectual disability. She has the cognitive skills of an 18-month-old, but the parents are treating her as if she's 5 years old, and there's just not a good match there. So if her mentality is around the age of 18 months, then her feeding skills are probably going to be a little bit closer to that. Some kind of a mental or behavioral health disorder in the child or the caregiver. So there have been multiple studies looking at maternal depression, parental anxiety, child anxiety. Any of those can make things worse. The result from, for example, for the maternal depression is that oftentimes the caregiver is not as involved and does not recognize the child's hunger cues. Another thing that's often overlooked is the environment. Is it a distracting feeding environment? So again, this kiddo I saw today, everyone sits on the sofa watching TV. There's no interaction. They're glued to the boob tube. The family's not sitting at the table. Another one that I see all too often is inconsistent mealtime scheduling, or quote, we don't have a schedule. The kid that's allowed to graze throughout the day, or somehow parents are inadvertently, and it truly is inadvertent, they're reinforcing behaviors by drawing attention to the tantrums, the feeding refusals, rather than focusing on the child's appropriate behavior. So examples include learned aversion, stress or distress, disruptive behaviors, food over-selectivity, not moving on to the next stage of feeding, grazing. This is a big one. So we want 3 meals and 1 or 2 light snacks. The kid that's in your office eating a little snack every time you see him or her, the kid who always smells the food, the kid who's always in the pantry eating food, they're never going to have those hunger, satiety signals. And so when the food is offered by the parents, they're not hungry. So they can get into this big battle. So that's a big problem, is the grazing. So let's talk a little bit about evaluating kids for PFD. So you have to start off with a history, as with everything. So something as simple as asking parents of an infant or toddler, how are you preparing the formula? Are you using a powder? Are you diluting the liquid? In some cases, parents can't afford the formula, so they might dilute it to save money. You have to ask about that. Are you adding anything to the formula to thicken it up? Cereal, pureed solids, one of the many branded thickeners. Are you adding that? Why are you adding it? Was it recommended by a dietitian? Or was it something that was from the tia, abuela, grandma? We need to find out about that. Feeding preferences, nutritional deficits, grazing, which I already talked about, and then the use of dietary supplements and oral nutritional supplements. So I basically ask about vitamins, calcium, iron, and any formulas. Does the child have any difficult chewing? When they eat, do they drool? Do they lose food or liquid from their mouth or their nose? And how did the child do with their transition? So at what age did the parents introduce baby food? At what age did they introduce table food? At what age did they eliminate the breast or bottle? How do they do with each of those? Did they hit any roadblocks? Oftentimes children who have a sensory-based feeding disorder will have problems immediately in the newborn, I'm sorry, not the newborn period, but with the introduction of solids. The parents offered them pureed starchy foods or pureed vegetables at 6 months of age as recommended, and the child refused to eat them. That's not behavioral. You can't have behavior problems at age 6 months. So that probably is more neurological. Are there any symptoms of oropharyngeal dysphagia? And then are there any maladaptive behaviors, refusals, tantrums, rumination? So rumination is basically a child who brings food up that's already been chewed and swallowed, re-chews it and re-swallows it. Pica, it's all lowercase. Some people make it into an acronym, which it is not. It's a lowercase, it's a word. Eating of non-food substances. And I don't ask parents if the kid has pica because they don't know what that word means. So I basically ask them, does your child eat hand lotion, soap, paper, rocks, dirt, hair, lint, clothing, poop? And yes, I do ask about poop. Some kids that are on the autism spectrum will eat that. So I ask about those things. You'd want to hear a no there. Sensory aversion, are they sensitive to the sight, smell, color, temperature, anything of the food? And then in those rare cases, when you have an infant, ask, does the child ever feed during sleep? Ideally, in an ideal world, we can do a feeding observation. It may be the mom or dad bringing the kid in eating nasty stuff from a fast food restaurant, but you might get an opportunity to see the child's positioning and posture. So if you picture how you're supposed to sit at your desk, you want 90, 90, 90. You want the back hip angle at 90 degrees. You want the knee angle at 90 degrees, and you want your ankles at 90 degrees. If the child is slouched over, that's not conducive to feeding. If the child has cerebral palsy and they have spastic quadriplegia and their neck is extended, that's not conducive to feeding. That's why a lot of children who have CP have a headrest on the back of their wheelchair to keep them in line. What is the child's hunger and satiety cues? Is the parent offering the kid food and the kid walks away from the food? They don't show any interest in the food. How do the caretakers respond to? How do they interact with the child? Is it back and forth? Is it reciprocal? Is it a mutual exchange? Is there socialization going on, or is it mechanical? What do the kids' oral motor skills look like? You don't have to be an expert, but you can tell if you've seen a 5-year-old and the food's falling out of his or her mouth, or they're drooling, that that's not appropriate. Or they're having dysphagia. I've had parents tell me my kid doesn't gasp or choke, and they take a sip of something in my office, and all of a sudden the kid is sputtering, and I'll ask them, what about this? And they'll go, oh, I didn't think about that. Examination, so you want to do a basic oral motor examination. Facial symmetry, you want to look at the hard and soft palate. So with infants, it's very easy. You just put your finger, your pinky finger, just like you do when they're newborns, in their mouth. You want to see if there's a submucous cleft or any clefting. Dentition, are their teeth worn out? Do they have a grill? Are their teeth nasty because they drink milk all day long or juice all day long? Okay, what does the movement of their lips and tongue look like? What's their voice? Do they have a gravelly, hoarse voice? Do they sound like they've been gargling with battery acid? Or maybe because they have severe GERD, or maybe because they're having other issues in that area. And then your cranial nerves. There's not a role for shotgunning laboratory studies. I actually rarely order them, and you should not be ordering them routinely unless they're indicated. So a child who has weight faltering, again, I'll repeat, weight to length ratio under the age of 2, or body mass index 2 years and over of less than 5th percentile, sustained. So you want to get a baseline study. So either a CBC or an H&H. The old adage, too much information is useless. So maybe just an H&H. Urinalysis, you're looking for protein, you're looking for creatinine issues. And that basic metabolic panel, looking specifically at the BUN and serum electrolytes. You also want to make sure the child doesn't have celiac disease. So each institution has different tests, but you want to basically test for celiac disease. If the kid is not just mouthing things, because the parents think that mouthing is pica. If the kid's actually eating, E-A-T-I-N-G, actually eating pebbles, dirt, rocks, any of that kind of stuff, go ahead and check an iron and a lead level, because it could be iron deficiency, or the kid could have acquired lead poisoning by doing this. Oftentimes it's behavioral, and it's also very common in children who have developmental disabilities. So taking care of these kids does not occur in a vacuum. Everybody needs to be involved. This is a team approach. So I'm not going to read this slide. It's fairly busy, but you can see that there are multiple disciplines involved. We have feeding experts. Those are the speech language pathologists, occupational therapists. We have the peds GI. We have registered dietitians. We have developmental pediatricians, and a behavioral specialist, either a psychologist or a clinical social worker. So you may have one, some, none of these available at your institution. You're going to go with who you can get. So management. So let's go back to that SGA baby. I told you that some of them don't catch up, 20% don't catch up. But the emphasis in the 1970s and 80s was rapid catch-up growth. They really pushed these kids to catch up and be big, but now research in the last 10, 15 years has actually shown that it puts those kids at increased risk for metabolic disease, diabetes, obesity, so we don't want that. excessive weight gain impacts the child's care and ADL. So I want you to think briefly about a child who has cerebral palsy. We actually want a child who has a developmental disability like cerebral palsy or any motor disorder to actually be a little bit below average. So in other words, below the 50th percentile. So if we can aim for a reasonable BMI or weight to length ratio of 10th to 50th percentile, it makes it easier for parents to transfer that child from a wheelchair to the bed or from the wheelchair to the toilet or into the bathtub. It also makes it a lot easier for occupational and physical therapists to maneuver the children, and it puts less stress on the child's musculature as well. So there's no advantage to having the child being big and burly. We don't want linebackers. So weight faltering. So those kids, you want to give them a complete multivitamin that has iron and zinc. These are sometimes hard to find. Parents will sometimes look for gummies, but those usually do not have enough iron or zinc. So it has to be a complete vitamin that the child will take. And then how do we increase energy intake of these kids? We can't get them to eat more volume unless it's Thanksgiving. So most of the time we have to sneak calories in another way. So we're going to use the same volume of food, but we're going to add calories with fats. So you can make their formula or fortified breast milk a little bit more calorically dense. And then you can add high protein or high fat foods such as eggs, cheese, cream, butter, peanut butter, things like that. Cooking oil, any of those things can be added. Avocado. These are things that you're just going to add a little bit, and they can really increase the caloric density of the food. There is a role for giving the child whole milk rather than skim milk, so there's some extra fat there. And then if there's an instant breakfast preparation available or non-fat dry milk, they can add that to it. You can call it super milk if you wish. So these are widely used. I see these a lot, but unfortunately there's not enough data. There are not enough data to support their use. So cyproheptadine, dronabinol, migestrol, oxandrolone, atypical antipsychotics. These are widely used. I do not use them because there's no evidence in the peer-reviewed literature to support them. They all have side effects. So I would recommend avoiding these. So we're going to talk about some food rules. 4 very powerful words that parents can use: kitchen open, kitchen closed, and we'll go through this. So kitchen is opened. We want a schedule. We want 3 scheduled meals and 1 or 2 light snacks. The child does not have free access to the cupboard or the pantry or the fridge. The parents must be in control of that. We want the child to be eating in the same room, the same table, and have the same utensils for every meal. We want it Groundhog Day. We want this predictable. Mealtime's no longer than 30 minutes. So all too often I see families whose child is kept at the table for 45 minutes, an hour, in some cases 2 hours, until, quote, they're all done. After 30 minutes, the kid's not going to eat. And it's just going to turn into a big battle. So the bottom line is at 30 minutes, parents just have to look at the kid and say, kitchen's closed, all done, and the kid leaves. In between meals, water, water, water. The reason for that is because it's non-nutritive, non-caloric, so they'll get a little bit of volume, and then it goes right through the stomach. The brain does not detect that as anything that's going to be filling, and so they can drink water freely, and it's not going to affect their appetite. We do not want these kids grazing. We do not want them drinking juice. We don't want parents coaxing or begging them. There's nothing wrong with juice, but I want you to keep in mind that juice is nothing more than sugar, even though it comes from fruit. So there's no reason why they can't have 4 to 6 ounces of 100% undiluted fruit juice. And my philosophy there is that if it's bad, then why are you diluting something bad? Just don't give it to them. So go ahead and make it full strength. Do not dilute it. That way they get a little bit of juice, full strength, maybe in the morning, water throughout the day, and then if they want to offer them milk, they can have milk with meals. Mealtime should be pleasant and enjoyable. It should not be a battleground. So we want everyone at the table together. Food should only be offered at the table. We do not want kids eating in their bedrooms. We do not want them eating in the sofa or at their sofa, and certainly not what I call drive-by eaters, where they come by, grab something, walk around the house, or like you see in your office, they're walking around their office eating food. Absolutely not. Atmosphere needs to be neutral, and we want to eliminate distractions. So that means at the table, no phones, computers, laptops, tablets, TV must be off. I've actually had more than one parent ask me, well, what do we do? Well, there's this new invention called talking. You could try that. But we want all those things off. We want people to interact with the meal. So bottom line is if the child is a wiggle worm, if they're a drive-by eater, then they stay buckled into either a booster seat or a high chair until they're able to keep their butt in the seat. This applies whether they're 12 months old or 12 years old with a disability. It's not to be mean. It's not to torture the child. It's just to let them know, hey, when you're in this seat, you're here to eat. And once your feet hit the floor, kitchen's closed. And I make it clear to parents. We do want toddlers and certainly school-age children exposed to same-age peers for one meal. So that basically means, if parents are able to, have them eat at daycare, have them eat at school, because they're going to learn some nice rules there. Never reward with food for any reason. I know that sometimes this is used as a reward in ABA therapy. I cannot control that, but we don't want parents rewarding with food. We want parents rewarding with praise. So a wink, a thumbs up, a high five, a kiss, words of praise, but not food. So this is a nice question, and you can actually ask parents in your clinic, because oftentimes you just tell them it's not going to stick. But I ask parents every day, how many times do you think you need to offer your child a new food before they'll start eating it routinely? And invariably, the dads will go once, and the moms go 3 or 4 times. Well, the actual answer is 20 to 30. So I tell the parents, you're not close, keep going, and they'll say 5, 10. I'll say go higher. Once they get 20, I'll say, yes, you're right. And their eyes will get big, and they are flabbergasted. It takes them that long. So when the parent has told you that they've offered their child a certain food only 5 or 10 times, they have a long way to go. Now that rule applies to neurotypical children only. So if you're talking about a child who has a developmental disability, it could be 40, 50, or 60 times. This will bring some peace and relief to the parents, knowing that, oh, I need to do a little bit more. It's not just me, it's not just the kid. We want caretakers to praise the good and ignore the bad. So if the kid throws a tantrum, they throw the food, they spit the food out, they say yucky, they push their plate away, no response. By the time the kid comes to your clinic, a lot of times they have developed what I call a parent remote control. And if they act a fool, it's like pushing a button and the parents respond by saying, no, don't stop, spanking, yelling, some kind of negative attention towards the child. It actually reinforces the behavior. So we're going to take that remote control away. What I'll tell parents is the end goal is for your child to grab food X, put it in their mouth, chew it, and swallow it without complaint. So the child does anything close to that. If they look at the food, if they touch it, if they smell it, if they lick it, if they put it in their mouth, any of that, that's going to get a wink, a high five, a clap, applause, anything to cheer them on. The kid is going to develop a new remote control, and they will learn, oh, if I act this way, I actually get a response, and now I don't get anything from the old way. And when he explains like that to parents, they'll understand. So we want everyone having the same food. The child needs to be involved in the food process from beginning to end. So that means, as painful as it might be to take little Bocephus to the grocery store, we want mom, Thea, whoever takes them to the grocery store, in the cart. I want that child to see, touch, and smell the carrots, the lettuce, the can of food, the loaf of bread, whatever it is. When the child gets home, I want that child to, air quote, help the parent unpack and put the food in the pantry or fridge so they can see it, touch it, and smell it. When the parent is preparing the food, I want the child in the kitchen, so again, they can see, touch, and smell the food. When the parent serves the food, I tell them, this is not a restaurant. I want you to bring the pots and pans to the table and serve from the table onto the plates. Everybody gets the same food, the same portions. That way there is no surprise. So this is the total opposite of what you and I do when we go to a restaurant. We look at a menu, we tell the waiter what to bring us, and they bring us the food and we don't know where it came from. We're adults, we can deal with surprises, but kids do not do well with that. They need to trust the foods. By doing what I just said, you can get a little bit of trust. At every meal on the plate, there needs to be one preferred and one non-preferred food. The reason for this is because if you only offer preferred foods, the kid's never going to expand the repertoire. If you only offer non-preferred foods, then we're going to have little Bocephus having fits and tantrums all day long. So in between is one of each. We want small portions. We're not trying to get the kid to lose weight, but what we're trying to get here is the child to tolerate that yucky food they don't like, and they'll eat the other one. So they'll leave the yucky one on the plate, and they'll eat around it, and they can ask for more. We want the child to take 1 or 2 bites, maybe 3 bites of solids, and then they can get their liquids, because it's much easier to drink than it is to chew and swallow. I already talked about juice, and I already talked about toddler formula, no sugary drinks. So unless the child is a professional athlete, which they are not to drink sports beverages, and we certainly don't want them drinking sodas, lemonades, anything like that. Milk. So we are the only animals on the planet that drink milk after infancy. And so I tell that to parents. And so if the child drinks milk, it's fine. If they don't drink milk, it's also fine. They will find other sources of calcium and vitamin D. If they are milk drinkers, maybe 2 cups a day, no more than that. Excessive milk can cause dental caries, constipation, and anemia. So again, by telling parents all of this, the job of the parent is to decide what, when, and where is going to be offered. The child decides if they're going to eat. This alleviates the parents of the need to threaten, force feed, punish, coax, beg. All that's out the window. They just offer the food, and the kid eats it, it's fine. If the kid doesn't eat it, it's fine too. So this is an oral motor issue. This is the little sputterer, the little cougher, the choker, the gagger, the puker. Then you want to send them to a feeding expert. That's either going to be a speech language pathologist or an occupational therapist, and they're going to go through this entire evaluation. Some of this has already been covered, but they're going to address the oral motor and sensory aspects of feeding. For treatment, some of them will use transcutaneous neuromuscular electrical stimulation, or NMES or E-stim. This has some evidence to back it up, but not entirely. If it's more of a behavioral issue as far as texture or appearance or something like that, then you would want that child, if possible, to see a team. We want to work on eliminating the behaviors that reinforce these refusals, and then determine what type of therapy to send them to. So briefly, I'm going to talk about enteral nutrition or tube feeding. So who gets or who needs a tube? So these are kids for whom oral feeds are unsafe, or for whom the oral feeds provide, it should say insufficient, sorry about that, insufficient energy or nutrients. So options are nasogastric, orogastric, gastrostomy, or gastrostomy jejunostomy tubes. And if you think back in the NICU, we always are trying to get those little preemies to bolus feeds rather than continuous feeds. So the same thing here. We want to avoid, if possible, this continuous overnight feeds. We want to go towards something that is more physiologic and natural, and that would be bolus feeds during the day. Parents are terrified when you talk about putting a tube in their child, and one of their immediate thoughts is, my child will never use his or her mouth again. And that happens sometimes, but oftentimes unnecessarily so. That often it results because the child forgets to use their mouth, and caretakers forget to offer food orally. So as long as it's safe, it's unusual for a child to be intolerant, safety-wise, of all food textures. Maybe they cannot have advanced solids, or maybe they cannot have thin liquids, but they can have other textures. So we want to keep the oral feedings intact as much as possible. So what are the benefits? How can we sell, so to speak, a G-tube to parents who are a little leery? It's safe and efficient. It allows catch-up growth, and it eliminates the pressure for parents to offer oral feeds. But everything has risks. So overly aggressive tube feedings can cause retching. It can aggravate GERD, and all too often I see kids that are actually overweight, obese. I've seen many kids who have short stature. Their weight and height are both below the 5th percentile, even below the 1st percentile. They're misdiagnosed as having weight faltering or failure to thrive, and they're being pushed on their G-tube feeds, and when you look at their BMI, they're 95th percentile. So please stop looking at weight and make sure you look at body mass index as the indices. And of course, if you're not feeding them by mouth, they're going to stop using it. So they actually will lose oral motor skills and some sensory skills. So we want to have that child experience all of that. The other thing is I do not want these children being fed in a clinical type setting. So all too often we'll have a home health nurse who feeds them in their bedroom, and they miss out on the experience of the family. So even though they may not be using all of the oral mechanisms, I still want them to be around the family to smell the food and be part of that social gathering. So the earlier in life that a gastrostomy tube is placed, the more difficult it is to remove it later on. Certainly if it's placed before the first 12 months of age, it's very difficult to remove it after that, but there are no absolutes. And then what's inappropriate is a child who can safely feed by mouth. They've had a video fluoroscopic swallow study. It was normal. They have seen a speech language pathologist or occupational therapist, and the child is deemed safe to eat, but they remain on the G tube. That's not appropriate. So we need to advance their diet orally. So I talked a little bit about this, exposing them to the environment, having them touch and interact with food, bolus foods, advanced oral feeds when possible, when safe. Feeding therapy must involve parents. So if we have a child who's getting any kind of feeding therapy, whether it's behavioral or oral motor, the parents must be there because they're actually the final therapists. Parents will often ask me, when can we remove the G tube? And the rule for most pediatric gastroenterologists is that the tube is not used for feeds, fluids, or flushes for 12 months. In other words, it's not touched for any reason. If it's not been touched for 12 months, at that point, most peds GIs will remove the tube. So, in summary, feeding problems and PFD are both common. Multiple factors contribute to PFD. Many of those problems are preventable or easily treated. Untreated PFD may result in complications, and treatment of PFD improves nutritional status, growth, feeding safety, and quality of life. Here's a list of references. There is also, should be a handout available to you as a PDF file in case you missed anything.
Thank you so much, Dr. Phelan. That was a very, very informative presentation. We do have just a couple minutes left, so I'm going to start reading some of the questions. We did have some questions come in while you were speaking. The first question is kind of a big one. It comes from Jana, who asked, how would you advise educating healthcare team about PFD so that it can become incorporated into practice? And then after that, or what's the first step to translate the definition into practice?
Jenna, that's a great question. So not knowing your background, it's hard for me to say which team you would be addressing, but I'm guessing most of the audience is pediatricians or family practice that see children. So I would actually bring it up if there's some type of a team huddle, morning report, anything like that, where you can start talking about this so it's not just occurring in a vacuum. This is something that your medical assistants, LVNs, RNs, everybody that takes care of these children on a daily basis can start recognizing, and it can get worked into the chart. As far as other allied health members, you probably are going to be teaching them because this article was just published recently, and it's not probably something that most allied health are going to be reading. So this is something that we're just trying to get the word out right now. And as far as putting this into practice, it can be very difficult. A lot of times, insurance does not recognize what feeding therapy is because it's done by speech language pathologist or an occupational therapist. I've had many of my PCPs try to order this, and insurance will try to put it into a little box that says speech therapy, or another little box that says occupational therapy, and it gets denied because the kid is already getting those services. So this requires, unfortunately, it's going to require a lot of advocacy on the part of educated physicians and healthcare providers.
Great. Thank you so much for that. I have a couple of kind of more practical questions. One comes from Elizabeth, who asks, when you say not to flush the tube for 12 months before discontinuing it, would you still need to flush it to keep the tube from being clogged?
So Elizabeth, I actually have posed that question to pediatric gastroenterologists because the question has come to me from parents. And I actually was under the impression that you had to flush the tube periodically, but Peds GI has told me that they don't want the tube touched. Now, again, this is coming from a lecture. So before you would propose that to a parent. I would check with your peds GI, but I've worked with peds GI in different settings at different facilities, and it's fairly universally accepted. But again, I would double check what your local practice is with that.
Okay, great. And then I think we can do, we're a little bit over time, but maybe one or two quick questions more. We have a question from Sweta who asks, can you please elaborate a little more on giving one preferred and one non-preferred food on their plate?
Sure. So Sweta, I'm sorry if I mispronounced your name. The reason we want to do one preferred and one non-preferred is because if the parents only offer what the kid likes, they're not going to expand their repertoire. And if they only offer them non-preferred foods, they're going to have a fit. So I always tell parents, we're all allowed to not like food. So for me personally, it's liver. If I saw a big pile of liver, I'm going to start upchucking and acting out and having a tantrum. And so I explain it that way to the parents. So if you offer a couple, 2 or 3 green beans or 2 or 3 carrot sticks, and then 1 or 2 chicken nuggets, the child is going to tolerate that most of the time. They'll eat their chicken nuggets or whatever their preferred food is. They'll leave the green beans there. But after they've seen those green beans or carrots or whatever it is, excuse me, 20, 30, 40 times, might accidentally touch one, might accidentally hold it in their hand, might accidentally smell it, put it to their lips or eat it. So that's why you always want the non-preferred food on that plate.
Great. Okay. Well, thank you. Unfortunately, we're 4 past the hour, so we're not going to be able to take any more questions. Thank you again, Dr. Phelan, and thank you to our audience. We really appreciate your participation. On behalf of the Nestle Nutrition Institute, we hope that you found this information useful to your practice and enjoy the rest of your day. Thanks.